if you remember previously, if you look to the third picture there is helix and antihelix. But with the prominent ear, usually there is underdevelopment of antihelix. You see this picture, it is not very prominent, the antihelix. And also the second etiology of the prominent ear is deep concha. You know, this part of the ear, if you look to the final picture, this part of the ear is called concha, if you remember. So if it is too deep, then it can lead to a condition called prominent ear. Okay, and the third congenital anomaly is the preauricular bits. Sometimes those patients will have like a few amount of discharge. And the fourth condition, congenital malformation, is accessory auricle. With accessory auricle, sometimes also associated with the other congenital anomaly in the external auditory canal or in the middle ear. But if there's no congenital anomaly with the accessory auricles, if it is just accessory auricle, then the treatment will depend whether the just to be like cosmetic. Good. Now we have what is called perichondritis or cellulitis. You remember in the last lecture we talked about the anatomy of the pinna, and we say that it is composed of cartilage, and the cartilage involves the whole auricle except the earlobe. And we said this will help us to differentiate between two conditions. So if the inflammation involves the whole pinna, then it is most likely due to be cellulitis. If it is like in the second picture here, on the bottom. While if it involves only the cartilaginous part of the auricle, so the diagnosis will be most likely to be perichondritis. Now, what are the risk factors that causing cellulitis or perichondritis? Before talking about the risk factors, we need to know what is cellulitis. I know many of you understand the definition of cellulitis, but the cellulitis, as you know, it is inflammation of the deeper part of the skin, so dermis and subcutaneous tissue. While perichondritis is inflammation of the cartilage. Okay, now what are the risk factors? Usually, cellulitis happen after having like eczema in the ear canal or acute otitis externa, sometimes due to skin lesions like psoriasis, or also from insect bite. While perichondritis, it is usually precipitated by trauma to the ear canal and like ear piercing. Now you know many of women using the earrings, and they start to use it in the cartilage. So just piercing the ear cartilage, it can cause perichondritis. Then what is the organism causing perichondritis? Perichondritis most likely to be caused by Pseudomonas aeruginosa, while the cellulitis, it is usually caused by Staph aureus. For that reason, it is important to differentiate between both conditions, because the treatment now is slightly different. So with cellulitis, we need to treat Staph aureus. And in this condition, we usually give co-amoxicillin. While in perichondritis, we need to manage Pseudomonas infection. And in this condition, we usually use oral fluoroquinolones like ciprofloxacin. Okay? In both conditions, topical fusidic acid cream may help to treat the conditions. Now, what are the differential diagnoses? We have what is called erysipelas, which is acute superficial cellulitis. So it affects the epidermis. It is not deep like in cellulitis, which affects the dermis and subcutaneous tissue. In erysipelas, the infection is involving the superficial layer of the skin. And it is usually caused by group A beta hemolytic streptococci. In this condition, the skin is bright red and well demarcated. Treatment is the same as cellulitis, is usually with antibiotic. Okay, the other differential diagnosis, it was called relapsing perichondritis. So relapsing perichondritis, it is an autoimmune disease. It is not like infection. How can we differentiate between them? With relapsing perichondritis, usually there are more than one cartilage involved with inflammation. So you can see like sometimes pinna involving the pinna and involving the nose. But this is, as I said, it is an autoimmune disease. It is not like a bacterial infection. Good. Do you have any question at the moment? Another condition, it is called pinna hematoma. So pinna hematoma, what is pinna hematoma? It is a collection of blood between the auricular perichondrium and the cartilage. Okay, so it is not between the cartilage and the skin, it is between perichondrium and the cartilage. And this is important to understand because we all know that the cartilage, any cartilage, receives its nutrients from the mucoperichondrium. So if there is any separation between mucoperichondrium and the cartilage, there will be a risk of nutrient deficiency and necrosis. And this necrosis can will be followed by fibrosis and a new cartilage formation. And if we don't manage pinna hematoma as soon as possible, the end result is like this picture. It is called cauliflower ears. Now, what is the most common cause? It's a blunt injury, usually due to contact sport, assaults, or sometimes any bleeding tendency. Just those patients who have bleeding tendency, even with minor trauma, they can have collection of blood. Okay? So from this talk, you can understand that the main management is drainage. So we have to drain hematoma either by aspiration or by incision. And then this should be followed by compression of the pinna. And there are different ways of compression we use, but it is enough for you now to understand we need to compress the area after drainage. This is important to prevent the recollection of blood in the space between the mucoperichondrium and cartilage. When can we use broad spectrum antibiotic. We use it only if there is delayed presentation and if there is a high risk of separate of infection. Okay. Now, another condition is called earwax. I think most of you or all of you heard about earwax and the how does it affect the a person. What is earwax? It is a mixture of desquamated keratin with lipid and peptide secretion. And as you know, the lipid is secreted from sebaceous gland and the peptide is secreted from the ceruminous gland. Good. And we talked in the previously about, I think we talked about this, that the usually the epithelium is migrated, the epithelium migrate from the umbo towards the umbo. You know, you remember the umbo, which is in the center of the tympanic membrane. So the epithelial layer migrate from there to the outwards and then to the ear canal, and from the ear canal to the outside. And if there is any problem with this migratory function, there is a risk. This will result in a risk of impaction of earwax. Sometimes also the earwax become impacted when it pushed medially in the external auditory canal, either with the cotton buds or with anything else. Then, is there any benefit from the wax? Yes, wax itself, it has a protective role in the external auditory canal, and its pH is about 5 to 7, and it has a certain, it has a role as antibacterial effect. So, when we need to manage earwax, we need to manage earwax or to remove earwax if there is an impaction or if there is a discomfort, and also if it affects hearing. So we have two ways to manage the earwax. One of them is just to do ear syringing, but this is associated with the risk of developing otitis externa, tympanic membrane perforation, or damage to the external auditory canal. And the best way to do is to have microscopic or endoscopic removal of earwax, of course, after softening of the earwax. And to soften the earwax, we use a softener, either olive oil or the dewax drops. Okay, I will repeat this, either olive oil or dewax drops. Good. This is otitis externa. Otitis externa is inflammation of the skin of the external auditory meatus or the auricle, or the outer surface of the tympanic membrane. So any infection in any part of the external ear is called otitis externa. And many predisposing factors lead to otitis externa. Heat and humidity. So it's some bathing, swimming, trauma, especially from dirty fingernails, or many people using cotton buds and hair grips to clean their ears, and this end with the trauma to the external auditory canal. Sometimes inherited narrow ear canals. Those people will face accumulation of the wax, and they need to clean it, clean the ear canals, and they can it can lead, and this can lead to otitis externa. Skin conditions like non-atopic eczema, psoriasis, all of these can lead to otitis externa. So all of these are risk factors to have otitis externa. Otitis externa itself can be classified into acute or chronic. Into, like, if it is within 6 weeks, so it is acute. It is more than 3 months, it is chronic. Also, we can classify otitis externa into diffuse, that involve the whole ear canal, or localized, that involve only a small part of the ear canal. And also, it can be classified according to the cause of the lesion, whether it is infective cause or reactive cause. So the infective causes can be bacterial, fungal, or viral. And the bacterial infection mostly caused by Pseudomonas aeruginosa, and secondly by Staph aureus. Parenchylosis, which is inflammation of the hair follicle, is usually caused by Staph aureus. Other causes, other fungal, the other causes, as I said, is fungal, and we have 3 main types: Aspergillus niger, Aspergillus fumigatus, and Candida albicans. Viral cause, either herpes simplex or herpes zoster. Now, what about the reactive causes? Reactive causes, from the name, is due to reaction. So any skin lesion can cause otitis externa, eczema, psoriasis, seborrheic dermatitis. Also, sometimes secondary to discharge from an acute or chronic otitis media. So, what is the history? What those patients complain of? They usually complain of ear pain. This is the most common presentation: ear pain, discharge, and itching, especially if it is associated with fungal infection. And also, they complain from sense of blockage and a mild hearing loss. On examination, there is what is called tragal tenderness, or pinna tenderness. So, the tragus, when you push on the tragus inward toward the external auditory canal, this patient will feel pain. And when you examine with otoscope, you will see the ear canal is swollen, erythematous, and also you can see some debris or discharge. In fungal infection, you can see mycotic debris, and these debris will appear like wet cotton wool in candidiasis, while in Aspergillus niger, you can see the black hyphae, black spot. Okay, sometimes tympanic membrane is difficult to be seen. What investigations we need to do is ear swab for microbiological culture, including the fungal culture and antibiotic sensitivity. Good. Also, it is important to ask patients when you take history about diabetes, because diabetes or immune compromised patients, they are at risk of having a severe type of otitis externa. And skin diseases is important because, as you know, it can lead to certain types of otitis externa. We called it reactive otitis externa. Management, it is very important to ask the patients to keep their ears dry, because, as we said, humidification is one of the risk factors of the otitis externa. Because of the pain, we need to give them analgesia, and there are different types of analgesia, starting from paracetamol, ibuprofen, or Voltaren. Topical antibiotic and steroid. We have different types of topical antibiotic and steroids. And also, it is very important to do frequent oral toilet. So what is oral toilet? Oral toilet, like cleaning of the ear canal. And usually we do this by under microscope. But if it is not available, then we try to just to clean the ear canal with section clearance as much as we can. Then, if those patients not respond to the above management plan, or if there is severe cases, particularly when there is a lot of pain and edema, then we need to insert special ear canal dressing. For example, an expandable Otowick. Okay, this Otowick is similar to this on the picture there. This is Otowick. Okay, so when we insert this small pack inside the ear canal, this will help to introduce or to help the separate of topical antibiotic drops to whole of the ear canal. يعني راح تفيدنا هذه، تدخل لنا القطرات اللي نستخدمها للمريض إلى أن تصل إلى أكثر أماكن الأذن. And the second point, this will help to relieve the pain inside the from the ear canal and from the edema. So if we don't have Bobwick, there is an alternative strategy, which is by using about 12 millimeter ribbon gauze. And this ribbon gauze impregnated with an antibiotic and steroid, a cream or ointment. Good. Is there any indication for systemic antibiotic? Usually we don't give systemic antibiotic for otitis externa, but if there is adjacent cellulitis involving the skin of the pinna or the cheek, then we have to give systemic antibiotic. Also, we have to give them systemic antibiotics if the patients are immunocompromised. And sometimes there are local factors that hinder the delivery of topical preparations, like narrow external auditory canal. Then we have to give them some systemic antibiotics. Okay? Do you have any question? If you have any question, you can write it in the chat. But now, what are the complications of acute otitis externa? So we have a condition called necrotizing otitis externa, previously known as malignant otitis externa. So this condition is not a malignant disease, it's not cancer, but it is a severe inflammation of the ear canal and the the inflammation of the ear canal and the periosteum. Why it is called like malignant? So we'll talk about necrotizing otitis externa few minutes later. Then, what is the second complication? Abscess. Abscess can be formed anywhere in the ear canal. It can be localized. Okay. Also, the otitis externa can cause venocellulitis, or even it can extend to the face. And in this case, as I say, we need to use systemic antibiotic. Acute otitis externa, especially if it is recurrent, can lead to fibrosis of the ear canal, and this will lead to chronic stenosis of the ear canal. And sometimes thin or even thick membrane will be formed, and this will end with what is called false fundus. So the يعني راح يصير thickening للاير canal. Sometimes even the thickening in the ear canal يصير وين؟ يعني يصير قريب على التمبانيك ممبرين. لما يصير قريب على التمبانيك ممبرين كأنه أنت راح تشوف لاير كاملة سادت لنا التمبانيك ممبرين وما تقدر تشوفوها. فإذا هي هذه complications of acute otitis externa. Necrotizing otitis externa, abscess formation, venocellulitis, even cheek cellulitis, and chronic stenosis. Now, what is malignant or necrotizing otitis externa? So in this condition, the otitis externa progress to an osteomyelitis. Initially, the osteomyelitis will happen in the ear canal and around the middle ear. Then it may spread to involve the skull base and petrous portion of the temporal bone. So when the infection involves skull base, there is a risk of having the cranial nerve palsies, and any cranial nerve starting from the 7th to 12th can be affected. Also, when the infection spreads to the skull base, it can lead to meningitis, sigmoid thrombosis, brain abscess, and even death. For that reason, it is called like malignant. But nowadays, it is better to name it as necrotizing otitis externa, just to avoid misunderstanding of the name by patients. Necrotizing otitis externa is usually caused by Pseudomonas aeruginosa, and it usually affects elderly patients with diabetes or other causes of immunosuppression. And they will have history of constant, deep, and severe otalgia. They receive antibiotic drops, and they being managed by ENT doctors for otitis externa, but without response. Okay, so when you examine them, you will see some granulation tissue over the floor of the deep part of the ear canal. So in the floor, usually you see like like the picture here, a granulation tissue. So if you see any patient, elderly patient with history of diabetes, severe pain, not responding to management and to drops, so keep in your mind these conditions might be necrotizing otitis externa. And if you see a granulation tissue, so it's most likely to be necrotizing otitis externa. So the diagnosis is mainly clinical, but we need high definition CT scan or MRI scan of the skull base to see the extension of the disease. It is just to see the extension of the disease. And also, we need to assess blood sugar, C-reactive proteins, just C-reactive protein, ESR, and full blood count as an indication for infection. Now, what is the treatment? The treatment is by giving IV antibiotics. And IV antibiotics should be for at least 6 to 12 weeks. So it is 6 to 12 weeks. And we need to monitor the patient by doing the frequency reactive protein and ESR to see if there is improvement. CT scan will not help us as a monitor because the infection of the skull base or the temporal bone is usually take time to resolve. We need to monitor patient with C-reactive protein and ESR. If we use the antibiotic for 6 weeks and there's no response, then we have to give them another course of antibiotic. We usually use third generation cephalosporin, and also we need to continue using topical antibiotic, which is in form of either gentamicin ear drops or ciprofloxacin ear drops. Good. Any question at the moment? What are the differential diagnoses of otitis externa? We have otomycosis, and otomycosis is a fungal infection. And as I said, it can be caused by Aspergillus niger or Candida species. And with Aspergillus niger, as I said, we can see like black spore. With Candida, we usually we see like wet newspaper. And 10% of otitis externa usually caused by fungal infection. How do we manage those patients? We need to do frequent microsection and also to use topical antifungal like clotrimazole ear drops. And we should use the topical antifungal not less than 2 weeks. So sometimes we use it for 4 weeks. And we should not stop it until we are sure that there is no infection. Okay. Now, what is furunculosis? Furunculosis, it is an inflammation of hair follicles. It usually affects the lateral third of the canal. Why the lateral third, not the deeper third? Because the outer third of the ear canal contains hair follicles, while the deeper 2/3 doesn't contain it. Good. And the most common cause, as we said, Staph aureus. And those patients usually present with severe discharge, and sometimes can just burst from the follicle and from the boil, and then patients can have mild discharge. But it is they usually present with severe pain. And on examination, you can see boil in the ear canal. Sometimes it is not very prominent, you can see just mild swelling, but usually there's a boil. And we need to give them antibiotic in terms of the oral antibiotic, topical antibiotic, and also we need some, if there is any pus or abscess collection, then we have to drain it. Now, another condition called herpes zoster oticus or Ramsay-Hunt syndrome. This condition is caused by Bacillus zoster virus. Those patients will have unilateral marks, severe otalgia, and facial paralysis, accompanied by a vascular rash in the external ear. Also, this patient will have rash involving not only the external ear, sometimes in the concave, in the reauricular region, and affect soft palate. Also, the anterolateral border of the tongue can be affected. And because of the involvement of the nerve, of the facial nerve ganglion, it also can be associated with sensorineural hearing loss, vertigo, and tinnitus are other features of herpes zoster oticus. So in those patients, we need early, urgent treatment with antiviral like acyclovir and steroids. Why? We say it is urgent because we need this to just to reduce the chronicity of the facial nerve paralysis. And also, it is important to reduce the period of post-herpetic neuralgia. Because those patients have pain due to the condition, we have to manage them with analgesia. And because facial paralysis sometimes can affect the eye opening and eye closure, then those patients will have, like sometimes, especially if it is grade 3 facial palsy, they will have incomplete ability to close the eye. So we need to give them some eye care. And this include giving them some eye drops just to keep the eyes to prevent dryness of the eye, and also we can use a patch just to cover the eye. Now, this is the last condition we'll talk about regarding the otitis externa. It is called myringitis. So myringitis, it is inflammation of the tympanic membrane. We have two types of myringitis, granular myringitis and bullous myringitis. The granular myringitis, there's a history of trauma to the outer surface of the tympanic membrane. For example, patients have a grommet or myringectomy or any external trauma to the tympanic membrane after doing ear syringing or microsection. Any trauma to the tympanic membrane, it can lead to this condition. Those patients will have recurrent episodes of painless otorrhea. so it's usually not painful. They complain of ear fullness or ear blockage. Hearing is usually normal. Sometimes it is mild conductive hearing loss because it is very close to the tympanic membrane. And on examination, we'll see, like, you see this, the tympanic membrane, and we said the normal color, normal appearance of the tympanic membrane is bearded gray color. You see this, there's some granulation tissue here, some granulation tissue here. So granular area over the tympanic membrane is the main presentation on examination. What we need to do to manage them, we give them topical anti-pseudomonal, antibiotics plus minus steroid. Bullous pharyngitis, it is viral, usually viral cause, and happens after having influenza virus or parasitary syncytial virus. And it is more common in children and in winter. Those patients will have sudden onset of severe pain, and usually it is followed upper respiratory tract infection. Those patients most of them will have normal hearing, but some of them, they can have conductive hearing loss because of associated accumulation of fluid behind the tympanic membrane. But also, for unknown reason, those patients, nearly half of those patients will develop sensorineural hearing loss. On examination of those patients, we'll see bubbles on the tympanic membrane. And those bubbles filled with the blood. And it can burst and sometimes can cause significant amount of bleeding. And if you can see here, the tympanic membrane is intact, and usually it's not perforated. So what is the management? Analgesia is very important because those patients will have severe pain. And usually the condition is self-limiting. But we use topical antibiotics to avoid any super-added infection. Okay, now, I know it is a very long lecture, but just in summary, we need to understand the difference between perichondritis and cellulitis, and also erysipelas. We said erysipelas is affecting the superficial epidermis, the superficial layer of the skin, and we said the causative organism and the difference in management of each condition according to the causative organism. With penohematoma, we said it is urgent because if we don't manage them, then there is risk of cauliflower ear. So we have to manage it as soon as possible. Regarding the earwax, you have to remember that it is usually managed by ear syringing, but with ear syringing, there is a risk of otitis externa. And then with otitis externa, it is important to understand the causative factors and also the how to differentiate fungal infection from acute otitis externa. With management plan, also with the management of otitis externa, it is very important to understand and to know that it is important to keep the ears dry. And we use it, our main management is topical antibiotic and not systemic antibiotic. The systemic antibiotic, there are some indications for systemic antibiotic. And also there are some indications for ear canal dressing. Malignant otitis externa, it is not malignant, it is not a cancer, it is just a severe infection that lead to osteomyelitis of the skull base, and it can lead to cranial nerve palsy and meningitis and death. And the management plan of this, usually IV antibiotic, it is not oral antibiotic, IV antibiotic for 6 weeks. Good. Very good. Any question? Some patients have history of acute otitis media or discharge. It's mostly from chronic otitis media. So discharge, and this followed by having otitis external. فممكن نشوف المريض عنده otitis external وبنفس الوقت perforated tympanic membrane وتصير mixed symptoms. Okay.